Good afternoon, and on behalf of the Bipartisan Policy Center, I'd like to welcome you to our event today on strengthening the nation's pandemic preparedness. My name is Dr. Anand Parikh, and I serve as BPC's Chief Medical Advisor. As we enter the third year of the COVID-19 pandemic, the U.S. is seeking to navigate itself out of this emergency phase. On the bright side, over 550 million vaccine doses have been administered to date, with 81% of Americans over the age of 5 having received at least one vaccination. However, there are still approximately 80,000 daily confirmed cases and 1,600 daily deaths occurring nationwide, adding to the total US death toll of nearly 930,000 Americans lost. While we combat the present pandemic, there's also the realization that it's not a question of if, but when we'll face the next pandemic. Policymakers in Congress and elsewhere are searching for solutions to enhance our level of preparedness. Last year, the Bipartisan Policy Center released a series of recommendations to position the public health system for the next pandemic, centered around 3 pillars of intergovernmental coordination and federal oversight, the 21st century public health data infrastructure, and adequate public health funding. Today, we'll explore each of these 3 areas with a particular emphasis on enhancing public health data exchange and interoperability in a conversation with a terrific group of national leaders and experts. We'll first hear from 2 members of Congress about the activities that they are leading, Senator Tim Kaine, who notably serves on the Senate Health Committee, as well as Congressman Troy Balderson, who co-chairs the House Pandemic Preparedness Caucus. We'll then be joined by Dr. Tom Frieden, President and CEO of Resolve to Save Lives and former Director of the Centers for Disease Control and Prevention, as well as former Senate Majority Leader and BBC co-founder Tom Daschle. Finally, Aaron Banco from Politico will moderate a discussion with Dr. Charity Dean, CEO of the Public Health Company, Dr. John Lumpkin, President of Blue Cross Blue Shield North Carolina Foundation, and Hemi Tawarson, Executive Director of the National Academy for State Health Policy. Thank you, and we'll now get started with our program with welcoming remarks first from Senator Tim Kaine and then Congressman Troy Balderson.
Hey everybody, Senator Tim Kaine here. It's a pleasure to join you via video today. I'd rather be with you in person, but this is second best. I want to start by thanking the Bipartisan Policy Center for hosting this important event and convening a group of experts to talk about pandemic preparedness. It's clear that the COVID-19 pandemic has taken an enormous toll on our families, our communities, and our healthcare infrastructure. The pandemic also shone a spotlight on some of the long-standing challenges and inequities that the United States public health preparedness systems have to address going forward. These challenges require that our country begin to prepare now for future public health challenges. That's why I'm so excited to be a member of the Senate Health, Education, Labor, and Pensions Committee's plan to begin and undertake a bipartisan public health and pandemic preparedness bill. We've got to pass bipartisan legislation that ensures the country is better positioned for the next public health crisis. We don't know when it will come, but we know it will come. Part of our effort has to include language to address our nation's public health data infrastructure. Our nation's public health system needs high quality, timely, and accurate data to protect the public from emerging threats and to respond to existing public health emergencies. We know that effective prevention and response requires significant coordination between healthcare providers and public health officials at the local government, state government, and federal government level. Yet for too long, the public health data systems we've relied on for our health and safety have been antiquated, fragmented, not interoperable. Systems lacking that interoperability needed to facilitate timely, secure information exchange do not serve us well. That's why last Congress I championed a bipartisan effort to modernize public health data infrastructure so that clinicians, state health departments, and the CDC could work together seamlessly to identify and respond to health threats. This legislation was signed into law in late 2019, and the CDC was just beginning efforts to implement these reforms as the COVID-19 pandemic struck in the first quarter of 2020. 2 years into the pandemic, it's clear that far more must be done. So that's why I'm working with the Help Committee on language included in the Bipartisan Prevent Pandemics Act to further address the issue. My own bill, the Improving Data in Public Health Act, which will be bipartisan and I'll soon introduce with a full complement of co-sponsors, will build upon Congress's initial efforts to modernize data infrastructure and improve communication at all levels of our public health system. This language was included in the bipartisan draft that the Help Committee recently released, and I thank the Bipartisan Policy Center and others attending this event because you've given strong support to the inclusion of this important priority. In addition to work taking place to address our public health infrastructure, we have to work in a bipartisan manner to address the long-lasting impact that COVID will have on our communities. And this includes the mental health of our frontline workers. In July 2020, I introduced a bipartisan bill to address the mental health impact of the pandemic on healthcare workers, the Dr. Lorna Breen Healthcare Provider Protection Act. The bill aims to reduce and prevent suicide, burnout, and mental and behavioral health conditions among healthcare professionals. Provisions modeled after my bill were funded by the American Rescue Plan, and just last month, the Health Resources and Services Administration released $103 million in funding distributed across the country to reduce burnout and promote mental health among America's healthcare workforce. This work is a step in the right direction, but we know that much more must occur. So as HELP seeks to undertake efforts to address mental health and substance use disorder, we must consider the effect the pandemic has had on our healthcare providers and on our frontline workers more broadly. I look forward to working with all of you on these important issues as we move forward. We've got our work cut out for us here in Congress. I'm grateful to have people like you advocating for important and bipartisan solutions. Thanks for the important work you do.
Hi, I'm Congressman Troy Balderson, a co-chair of the Pandemic Preparedness Caucus. First off, I want to thank the Bipartisan Policy Center for hosting this event. Pandemic preparedness must continue to be a top priority for our country and Congress moving forward. COVID-19 has forced us to reevaluate the state of our national pandemic preparedness and response. While we have been successful in certain areas such as rapid vaccine development, we have faced challenges in others. Congress has worked in a bipartisan way toward better and more efficient public health preparedness. Our caucus will work with House committees to address the nation's biggest needs, such as supply chain issues, modernization of our national stockpile, and research into future pandemics. A major issue that our country faced was the effects of antiquated systems at the local, state, and federal level. Updating our public health data infrastructure is vital. I have heard countless times how the tracking systems within our hospitals have contributed to shortages. Updating these systems will ensure our frontline workers have the critical supplies they need when and where they are needed most. It will also ensure products in the stockpile are unexpired, up to date, and maintained. This is why I am proud to have worked with Representatives Gottheimer and Hudson to introduce legislation that will combat equipment shortages, update our health data infrastructure, and provide near real-time tracking of medical and health supply inventories nationwide. Another area that must be addressed is related to supply chain. We saw in all sectors of the effects of our over-reliance on foreign entities causing disruption in our supply chain here at home. Congress has been working to reduce Americans' dependence on foreign suppliers to produce critical goods such as medical supplies, PPE, and pharmaceutical ingredients. Bringing more domestic manufacturing back to the U.S. is something we will continue to push for. Our country must always continue the advancement of research and development into medical countermeasures. I've had the opportunity to see firsthand some of the amazing research being done into pandemic preparedness. One academic medical center I worked with closely in Ohio is using their veterinarian center to build robust collaborations to prevent future pandemics. The need to bolster these research and continue the incredible work being done in this area is paramount. There is a lot of work still to be done at both the federal and state levels to better prepare us for the prospects of a future pandemic. These ideas are just a start, and some of the recommendations laid out in your report released last year provide good insights on how we can better prepare. Thank you again for this opportunity, and I look forward to working with you as we position the United States as a leader in pandemic preparedness.
Thank you, Senator, and thank you, Congressman. I'm honored now to be joined by Dr. Tom Frieden, and Senator Tom Daschle. Good to see you both. Dr. Frieden, Senator Daschle, thank you for being here.
Great to be with you.
Dr. Frieden, I'd like to start with you. You've been such an important thought leader and communicator for the country during this pandemic. Before we get to pandemic preparedness for the future, can you share your outlook or forecast for 2022 for the U.S. with respect to the current pandemic?
I'd like to start with what's certain, what's likely, and what's uncertain. What's certain is that we are better prepared than ever to deal with this virus. We have more immunity, more vaccines, more treatments, better understanding of masking and ventilation, more tests, more surveillance, more genomic surveillance, more wastewater surveillance, more awareness. So we are better able to deal with what COVID may throw at us. That's certain. What's likely? I think we will have a much brighter 2022. I think we're going to have a year in which we put the most disruptive aspects of this pandemic behind us. We'll still be dealing with people with long COVID. We'll still be dealing with cases and clusters and hospitalizations and tragically with deaths. But I do think that 2022 is the year in which we stop having this virus dominate our lives to the extent that it has in the past. But I'll tell you what's uncertain, and this is what concerns me most. What's uncertain, first, is we don't know what the virus is going to do next. The virus is adapting to people. We need to adapt to the virus. We don't know what future variants will hold, nor do we know how long immunity will last, nor do we know really optimal vaccine scheduling and series. We're going to learn that with time. But most importantly, what we don't know is whether or not we will seize the moment. We will seize the moment to strengthen public health in this country, to strengthen global public health capacity so that we can achieve something like the goal of 717, where every single outbreak is identified within 7 days, reported in 1, and control measures established within 7. That's what's in the balance for 2022, and it's really in our hands. There has never been such a teachable moment. There has never been an opportunity to make the kind of progress we have today, the opportunity to making our world safer and healthier. So 2022 is really decision time for whether or not the world becomes a safer, healthier place.
Thank you. So some certainty, some uncertainty, but a tremendous opportunity. Senator Daschle, would you like to add?
First of all, let me just say what a pleasure it is to share the dais with Dr. Frieden again and thank him for all of his leadership and his good work, especially these last couple of years. And let me just say, I agree with what he has just said completely. My hope is that policymakers in particular are going to recognize the urgent need for a transformational investment in our country's pandemic preparedness infrastructure. If the last 2 years haven't provided a clear rationale for this investment, I really don't know what will. But I have to be honest, my fear is that the nation has collectively decided that it's done with the pandemic, and that in an election year, especially, I'm concerned a little bit that policymakers are only too happy to agree with him. I don't pretend to know what will happen with COVID-19. Dr. Frieden is a lot better an expert than I am on that. But I will say that most experts have spoken with doubt that the Omicron will be the last variant we face. There's even talk of a new one as we speak. So I hope that this can be a moment where we unite as a nation to ensure that we're better prepared for what comes next. But I have to say that as much as I'd like to be optimistic, I'm still concerned about whether we seize this moment. The best time to prepare for the next pandemic was a decade ago. The second best time is now. And I don't think anything could be more applicable to our current circumstances than that. It's clear that COVID-19 is going to be with us for the foreseeable future. That is not arguable. And it's not a question of if, but when the next pandemic emerges. That's not at all arguable either. So this could be an influenza pandemic, like the 1918 pandemic that infected an estimated third of the world population, killed about 50 million people. We all know that history. It could be another coronavirus pandemic. It could even be a man-made pandemic, like an engineered strain of smallpox. All have the potential to be far more devastating than COVID-19 has been thus far. Congress appropriated emergency funding that shored up our economy and and help develop, deploy, and successfully distribute tremendously successful vaccines and therapeutics. And so we've seen what that can do. But despite these investments, we're still, I think everyone would acknowledge, in a very precarious position today. We may have bailed out the water from the boat, but it's still not seaworthy. So I would just urge on a number of things. First, to act now to appropriate sustainable, right-sized funding for our nation's public health infrastructure and pandemic preparedness. That includes a multi-year appropriations process so we can provide greater certainty so that our nation's public health agencies and private sector partners can really make the necessary long-term investments. That, to me, is absolutely essential. That's the foundation. The Bipartisan Commission on Biodefense that I've now served on for a number of years proposed a $10 billion, 10-year, what we call Apollo program for biodefense. These are the kinds of transformational investments that we really need right now. So the time is also right, besides that, to make a very important policy change to ensure our federal agencies are better prepared for the next pandemic. And that change, I think, is well articulated in the so-called Prevents Act that Senator Murray and Senator Burr have now introduced, the Prevent Pandemics Act. I applaud them for their good work in that regard. We still have a long way to go. The bill's only been introduced, so we still have a ways to go before it's enacted. And so that's number two. We've got to have a good policy framework. And then third, I think it's critically important that we have mechanisms to provide transparency and accountability to these efforts going forward. BPC's Future of Health Task Force has proposed, I think, some great ideas with regard to the creation of a national board on pandemic preparedness, which would establish a set of metrics and benchmarks for evaluation of federal and state pandemic preparedness capacity. And it would gauge how nations how this nation, and frankly, we could extend it to other countries as well, but really how this nation is faring against these metrics, and then develop an annual report mechanism with specific recommendations on how we can adjust to ensure that we're ready for the next time. So these are some of the ideas that I would have, and I'd be happy to take part in discussing any of this going forward.
Thank you, Senator. Dr. Frieden?
Well, thanks. And first, I do want to add my thanks to the Bipartisan Policy Commission for all of your work in this area and for, of course, this event. And I'm honored to share the virtual podium with Senator Daschle and thank him for his leadership in this area and so many areas over many years, and look forward to continuing the collaboration as we move forward. To me, the single biggest issue that we have to deal with is funding. And there's an old saying, if you keep on doing what you've always done, you'll get the results you've always gotten. And unfortunately, the results we've always gotten with public health support are very problematic. And we saw that during the pandemic. We saw that partly because what we've had is a boom or bust cycle, panic and neglect. We saw this after Ebola. We saw it after Zika. We saw it after H1N1. We saw it after smallpox. We saw it after anthrax. We saw it over and over. That's why it's so critical that we invest, as Senator Daschle says, and as the BPC report indicated, in public health infrastructure. It's easier when there's an emergency to get supplemental dollars. But as someone who's run a public health agency, I can tell you, you can't build a sustainable program on one-time dollars. It just doesn't work. You end up with this flood of money that comes in. You do your best to use it well, but if it's building systems, whether they're data systems or developing staff or building an infrastructure or establishing partnership with states and cities and counties or different organizations or even industries that you're purchasing from, if you don't have sustainable dollars, you can't do it effectively. So unless Congress ensures long-term sufficient sustainable funding, they will not be able to keep the faith with the American people. What's the first responsibility of government? It is to keep people safe. And right now, we're falling down on that in this country because we're not funding public health substantially and we're not funding it sustainably. That's why we suggested nearly 2 years ago the Health Defense Operations Budget Designation, or HDO. BPC has a similar proposal, different acronym of BIO. Senator Daschle has been in the lead in advancing this, and we've seen bipartisan support in Congress and outside of Congress. The concept is a simple one. Anytime protecting from a long-term public health threat has to do battle in the budget battle with more urgent, more popular, more apparent, more immediate beneficial needs, public health is going to lose. And so the only way that we can see to have sustainable funding for public health is to have a set of discretionary budget lines that can not be subject to the budget caps, but would be overseen by Congress, specifically by something like the Pandemic Board, and could then assess how the country is doing on something like the 717 metric that we and others have proposed, where every single outbreak is identified within 7 days, reported within 1, control measures in place within 7. That's the kind of accountability framework and quality improvement system that could transform our public health efforts so that we're able to find things faster, stop them sooner, and prevent them wherever possible. And that's the bottom line. It's not going to be quick. There are no quick fixes to this. There's some great new tools, really exciting genomic surveillance, wastewater surveillance, some of the new informatics ideas, many different information streams coming in. But ultimately, it comes down to, do you have an effective public health system at the local level, connected with the healthcare system, that identifies when there's a problem, investigates it promptly, and takes appropriate and rapid action? And that problem could be COVID. It could be a tick-borne disease that spreads as easily as Lyme and is as deadly as Ebola. It could be the next drug-resistant organism. But the bottom line is, unless we have that public health infrastructure, we won't be able to protect Americans effectively, and we won't have that effective infrastructure unless we fund efforts sustainably in this country, and we engage globally with entities like the Global Fund, the World Health Organization, CEPI, and others to ramp up preparedness so that the next health threat is found where and when it emerges. Thank you.
Thank you, Dr. Frieden. I want to talk about the CDC for a moment. As you know, the agency has received some criticism on its response to the pandemic. How do we make sure moving forward that the CDC is strengthened, particularly with respect to the public health data infrastructure, so it can meet the expectations that the American public have?
Well, I don't think there's any institution in the world that can look back on the COVID pandemic and say we got everything right. And certainly CDC deserves some of the criticism it's getting. I think, frankly, there's been something of a piling on to CDC. They're doing a lot of things right. They're making a lot of good decisions, but that gets lost in the media hype of what's happening. There does need to be a better informatics system in this country. CDC is subject to the reality that our hospitals, our health centers, our laboratories, our public health departments are all quite disconnected, and they all work differently. And CDC has very limited authority to try to standardize that, with full respect for confidentiality, full respect for states' autonomy. There's still a major role that CDC is not able to play because of a combination of insufficient funding and insufficient authority to establish the kind of data standards to move forward. It needs to do that in a way that collaborates with states, cities, counties, as well as the private sector. But also it needs to be recognized by all of us that this isn't going to change quickly. The data infrastructure of this country is behind, just as much of our other infrastructure is. And it's going to take many years of dedicated dollars and focused accountability to make sure it improves.
Thank you, Dr. Frieden. Senator, maybe more broadly, moving beyond pandemic preparedness, and you've already touched on this, how do we help policymakers recognize the life-saving role that public health really plays in our country as a key element of our nation's infrastructure, given that you can't really have a pandemic response without a robust public health system or a public health data infrastructure. Both you and Dr. Frieden have alluded to this, but maybe if you can reflect on this a little bit more.
Well, first of all, let me just say on how strongly I agree with Dr. Frieden's comments about the CDC. I do think that everything he said is exactly right. We really have to ensure that they have the resources, and we put the emphasis on transparency that I talked a little bit about a moment ago. But when it comes to public health, I think it all starts with changing the way we talk about public health. It's really, that's basic. I couldn't be more emphatic about the need for us to be more clear about how directly our nation's health is tied to national security. We don't do that today. We don't look at health as a national security issue. And I think it has to start with that. National security is viewed by nearly all policymakers as a necessary investment, while public health is often viewed as helpful, but really not essential. So I think it starts with our mindset and how we look at public health going forward. Public health infrastructure is infrastructure. And just as we see a tangible impact from deteriorating roads and bridges, we saw all over the last couple of years the real impact of years of what it has cost the United States and the people of our country in underfunding public health. Just like roads and bridges, this infrastructure just can't be restored with a one-time emergency funding program. Continued right-size investment is needed to ensure that we not only retain the capacity and expertise that has been developed over the past 2 years, but we make improvements for the future as well. And I think, lastly, I think policymakers have to stop vilifying public health officials. I see too much of it. It's demagoguery at its worst. Public health officials are public servants, not public enemies. And if we as a nation want to support science-based decision-making and improve communication and transparency, we should invest in those capacities at the federal, state, and local levels.
Thank you, Senator. Dr. Frieden, the last word in this session. We have about 30 seconds. Any final comments from your perspective?
Senator Daschle says, we need to see public health not as a nice to have, but as a must have. And I'll leave you with two last quotations. First from Tom Cole, when he was chair of the Labor Age Appropriations Committee, he said, it's a no-brainer to spend billions to save trillions, because you're much more likely to be killed by a pandemic than by a terrorist. And that was 5 years ago that Congressman Cole said that. And second, in terms of how to message this, on one of my first trips to Washington as CDC director, I met with then Senator Inouye, wonderful senator since passed. He was chair of appropriation, and I asked him this very question: how can we get more support, particularly for global public health? And he said memorably, don't tell us the good things that will happen if we give you the money. Tell us the bad things that will happen to us if we don't give you the money.
Thank you, Dr. Frieden. And thank you, Senator Daschle, both of you, for your insights today and your leadership. We hope that policymakers listen to your advice and that we can move forward in the future better prepared so that we can have a better response. Thanks again to both of you.
Thank you.
This time, we'll move on to our panel discussion, and I'll hand it off to Aaron Banco from Politico to lead the discussion with our distinguished experts. A note to the audience, please feel free to send any questions you may have through the chat or Twitter, and we'll try to integrate as many of them into the discussion as possible. So with that, Aaron, welcome, and thank you.
Thanks so much for everyone being here today. My name is Erin Banco, and I'm a healthcare reporter at Politico. Just to echo what was just said, attendees, please submit questions using the live chat on YouTube or Facebook or on Twitter using the hashtag BPCLive. I'd like to get started talking a little bit about who we have in front of us today. Let's start with Hemi. Hemi Tuerson is the executive director of the National Academy for State Health Policy, a nonpartisan forum for policymakers across state governments to communicate innovative solutions to health policy problems. Tuerson came to NASHP from the Duke Margolis Center for Health Policy, where she has been a leader and was a leader of the center's health policy portfolio. Hemi also served in health policy roles at the National Governors Association Center for Best Practices and the Office of the General Counsel at the U.S. Government Accountability Office. Hemi holds a JD and an MPH from George Washington University, as well as a BA in psychology from the University of Pennsylvania. John Lumpkin. Dr. John Lumpkin is the president of the Blue Cross and Blue Shield of North Carolina Foundation, a private charitable foundation committed to addressing the key drivers of health to improve the health and well-being of North Carolinians. Previously, Dr. Lumpkin worked as a senior vice president of programs for the Robert Wood Johnson Foundation, a role that he took on serving for 12 years as director of the Illinois Department of Public Health. Dr. Lumpkin earned his MD and MBS degrees from Northwestern University Medical School. He also holds an MPH from the University of Illinois School of Public Health. Charity Dean. Dr. Charity Dean is the CEO, co-founder, and chairman of the Public Health Company, a California-based firm that offers a platform that combines public health data, expertise, best practices, and genomic epidemiology to empower organizers to respond to communicable disease threats. Previously, Dr. Dean served as the assistant director for the California Department of Public Health, serving as a key figure in the state's response to the COVID-19 outbreak. Dr. Dean holds an MD and an MPH in TM, Master of Public Health and Tropical Medicine from Tulane University. She earned a BS in microbiology from Oregon State University. Welcome, panelists. Charity, I'd like to start with you. I'm wondering if you could give us an overview of how the COVID-19 pandemic exposed some of the long-standing data gaps and data infrastructure problems that exist within state and federal health agencies and just generally nationwide. And then also, what impact did those gaps have in our ability to track and contain outbreaks, including COVID-19?
Thank you, Erin, for that question. And it's truly a pleasure to be with all of you. Thank you for this important discussion. I would start by rewinding the clock to pre-COVID. As a local health officer and then a state health officer dealing with many different communicable disease threats, we knew at the local level that the data or intelligence we had was generally siloed, slow, based on antiquated technology or systems, tended to move at a much slower rate than the pathogen, and really depended on human vigilance. And so heading into COVID, all of the amazing heroes that are local health officials who did a phenomenal job knew at the outset of that we would not have the real-time intelligence that we needed, and that the silos of the data that were antiquated, slow-moving, sometimes largely academic, needing certainty, would not be able to make fast decisions in a setting of uncertainty. And so from the very beginning, the United States did not have a viable shot at containing this threat, simply because our system was not designed to do that. Throughout the COVID pandemic, again, what we saw is that it's just a truth that you get the results from the system you've designed, and that the design of our system with siloed data that's largely unidirectional, based on antiquated methodologies, faxes, phone calls, emails, that didn't work for real-time intelligence. And so I would say, I think the biggest lesson from COVID is that our humans didn't fail. We saw healthcare workers, public health officials, private sector leaders really run and engage in the response, providing the intelligence they could. I would highlight Operation Warp Speed and the scientific community as a shining success. But I think the biggest lesson is that we will get the result from the system we have. And I would say this was a systems failure for the United States. If I had to assign a letter grade to it, I would say the US got a D-, maybe an F. We failed at containing or really mitigating the early response because our system wasn't designed to. It's time for a system that is designed to do that, meaning rapid threat identification and intelligence platforms. And I believe we can build that.
Hemi, I'd love to home in on the point Charity made. Can you give us your perspective on how important it is for state and local health agencies to have reliable data systems and strong surveillance networks to track disease outbreaks? I'd love if you could give us sort of an on-the-ground perspective. What happens when those surveillance systems are either overwhelmed or, as we saw during COVID, or break down in some instances? Does that impact how local officials implement public health measures and policies?
a lot during this pandemic. And, across the country, I work across. Okay. Thank you for having me in this great discussion. It's such an important topic and a critical time to be talking about this. So, yes, I think at the state level, we really saw that there were some failures of the data systems. And, to Charity's point, state officials, local public health officials doing everything they could to try to make do with what they had at their fingertips during a pandemic. So a couple examples. So, vaccinations. There was a rollout of vaccinations. We were trying to get it out very quickly, as quickly as we could with a limited supply. And then as the supply grew, the populations who were eligible grew. And the ability to really track and understand who was getting vaccinated, at what point in time. And, there was all those categorizations of the priority groups, and really a want for having public transparency around the data. And we were behind on all of that. There was one state we worked with, they actually built a separate vaccination immunization system because they knew their old system would not be able to support the volume of those who needed to get vaccinated all at the same time. We wanted to think about okay, where do we have gaps in the community? What are the disparities among, communities of color and other demographics? And really, they did not have the ability to break down that data in the beginning, and states were just starting to gather it and starting from scratch in some places. So I think that just really exposed the gaps in the system. I think, we heard from the private sector, health plans wanted to step in and try to help with vaccination efforts. They didn't have access to the records because the data systems couldn't handle it, and also because of older laws that were on the books that really prevented those immunization systems from sharing the data externally with other folks. Privacy is very important. It's not that we don't value privacy, but in a pandemic, there has to be a way to be able to have partnerships and the ability to bring in other folks to help you in an effort like that when you're trying to get people vaccinated as quickly as possible. I'll say the other example I have is just the staff. Public health officials are, overworked, and there hasn't been the investments in terms of, the numbers and the capabilities that they need during a pandemic like this. And so I think that really was very evident. And I've talked to a number of state officials that say, we don't have the IT expertise in-house. When we really think about upgrading systems, and now there's federal money flowing, and I think we can have a conversation around the sustainability of that funding, but there is federal funding flowing at the moment. But there's limitations on the staff and what they're able to do, and think about what comes next in terms of the IT improvement. So lots more to talk about, but definitely some things that we saw in the beginning and now during this pandemic.
Thanks for that. Okay, let's talk a little bit about reforms and sort of how we move on from here, preparing for the next pandemic. I think the public health data infrastructure problem should, be front and center when we talk about pandemic preparedness, especially when it comes to U.S. pandemic preparedness. John, officials and academics have been studying the public health data infrastructure problem for more than a decade, right? While some improvements have been made at the federal and local level, due in large part to funding from Congress and the CDC, the way the U.S. collects this data is still by and large outdated and aggregate. What reforms are needed now, as we're sort of seeing cases hopefully come down from COVID, to ensure a robust public health data system that can detect and respond to ongoing and emerging threats in the future?
Thank you, Erin, and thank you to the Bipartisan Policy Center for having this very important conversation. William Gibson, the science fiction writer, once said that the future is here, it's just not evenly distributed. And that's the challenge with our public health data systems. Here in my home state of North Carolina, when this pandemic started, reports were coming in by fax, if you remember what that is, and by paper, again, if you remember what that is. Yet, there's been an effort that began 5 years ago with a project I was working with called Digital Bridge, where public health, electronic health record vendors, and healthcare got together and said, can we move data between public health and healthcare systems? This system became electronic case reporting and was turned over to the CDC in 2019. In January of 2020, just as we were learning about this novel virus that was first identified in Wuhan, there are only 4 centers in this country that could collect that data. Now it's up to 10,000. And the important thing about this, it's an automated system. It's an automated system that is standard-based and interoperable. What that means is that electronic health records across the country can contribute data into the system so that it rapidly gets to public health agencies. And those agencies can then ideally rapidly analyze it. But without support to the public health data system, those pieces just aren't in place yet. If we can agree upon funding the data system in a consistent way, not in the peaks and troughs that Tom talked about earlier, but importantly, that we do it in a standards-based way. And I'll just finish up by making one analogy. In the 1800s, one of the major things that made our country competitive was the railroad system. We did not build a railroad system with every state deciding how wide the tracks should be. And if you can imagine moving trains from one part of the country to another, if they had to change the size of their engine, every state would be a nightmare. Our public health data system can no longer allow each community, each state, each federal agency, each branch in CDC to come up with their own data standards. We need a platform of unified, interoperable data standards, and they have to be mandated and backed up by being a requirement for funding through data modernization.
Thanks so much for that. Hemi, I'd like to come back to you for a moment. You were speaking before about how every state is different. You know, some states have dozens of staffers who can help with this data collection and analysis and contact tracing, while other states really only have 1 or 2 people who can do this. You know, I'd like to talk to you a little bit about how we fix that problem in and of itself, right? If we make corrections and we create these standards and we get everyone on the same page about what the data needs to look like, how we're going to analyze it, but then, you know, say another pandemic comes along and these local public health offices are inundated with too much information, right? Too much data. How do we ensure that these local and state and regional health offices have what they need to be able to handle that influx, you know, in times of pandemics or endemics or infectious disease outbreaks?
Yeah, it's a good question. I think there's so much building block work to be done that we need to get to a level playing field before we even get to the question of, okay, well, one state has more capability than another. I mean, we are so far to John's point about having interoperable data standards and just really a baseline of what all public health data systems should look like. I think there's so much room to grow, even if you have limited staff. There just hasn't been the focus on what should the capability look like in public health? How should it connect to other parts of the healthcare system and the private sector? What should the capability be as a baseline across states? And I think if we have sort of reasonable markers, understanding that a state like California has a lot more resources than another much smaller state, I think there's just been no attention or uniformity in thinking about where to go. And I just wanted to give an example. So, we have all this ARPA funding flowing to states. It is time limited, which means there's going to be limitations on how states will be able to spend it because they'll be concerned about having sort of sustainable costs after the end of the grant. But, in Massachusetts, there is a law that was passed and the governor signed it into law. They're allocating $200 million, for local and regional boards of public health, focusing on standardizing data systems, increasing training, software upgrades, and technical assistance. So to the point is they're trying to create a level playing field, knowing that there are these gaps amongst all their different parts of the public health system. There's another state that's trying to use some of that ARPA dollars to really build a dashboard that connects Medicaid and public health records. That, again, I think that's a fundamental interoperable standard that all states should be able to do, right? You should be able to understand who in the Medicaid population has been vaccinated or not, right? It's just one example. I think there's a lot of other connections that can be made. And that is something that needs, I think, guidance, sustained investment, not just time-limited dollars. I look at the Medicaid system that has the 90-10 match. You get 90% of your federal matching dollars if you're upgrading your data system. We have a lot, the Medicaid data systems aren't perfect, but they've made a lot of progress because of that sustainable funding, right? Even smaller states, right? They've contracted to upgrade their systems. They've been able to hire in IT expertise because of that 90% match. So I think if there is sustainable funding and focus, I really do think there needs to be guidance and, to John's point, interoperable standards that states and local public health can follow. They'll be able to make progress no matter how limited their staff is compared to another state.
Before we move on to the funding question, which I'll leave open-ended for all of you, Charity, I'd like to come to you. There's this question of reform is on the table right now. And I'd love to know, in your opinion, who's responsible for this reform? And, is it the state itself? Is it the CDC? I'm sure you'll say it's everyone in between. It's collaboration. But I'd love to hear your thoughts on that. And then also how the private sector has been involved in these conversations around data modernization, public health data, and reform.
Thanks, Erin. Well, my response might surprise you, and I would go back to something Senator Daschle said that I wholeheartedly agree with. This is a matter of national security. Worse threats are coming, and COVID is with us for a while. So I think the right way that I ask myself the question is, if the United States of America needs a real-time threat identification platform with information that protects our economic security, our national security, and our health security, who is best positioned to build that, and what partners should be at the table? And my answer is, this has to be a public-private collaboration, and this has to be across all the relevant federal agencies. This cannot be built by or for any one federal department, including the CDC, but rather it has to provide real-time threat identification across DoD, HHS, National Security Council, for the protection of the whole country. And so I believe the conversations being had at the federal level must contemplate the role of the private sector, because it's a critical partnership. And we saw that throughout COVID, that the private sector capabilities, including in biopharma, but there's a number of examples, played a critical role. And the way that I see this, from a public health perspective, but also from a technology perspective, is that we actually have the technology today to develop the kind of data integration platforms that John and Hemi referred to. I 100% agree with them, but it has to consider all the capabilities the private sector has, all the things we've developed in networked real-time intelligence platforms, like we see in cyber, like we see in other threat identification platforms. So I do believe this is a matter of national security, and because of that, it is too important to have it built by or built for any one department.
Thanks for that. I'd love to move now to the funding question, now that we have some ideas for reforms on the table. States across the country right now, like Hemi said earlier, federal money is flowing into state public health departments to try and make some of these improvements. But from everyone I've spoken to, and I'm sure you all have heard this as well, it's not enough. And the fear is that that funding will go away. I think that has been the fear for decades in public health, that when we see things like pandemics or endemics, we get, I think Dr. Frieden said it was like a boom and bust cycle, right? We get a lot of money thrown at public health departments, and then it quickly goes away and people forget. So how do we fix this funding issue? John, I'd like to throw that to you.
Well, part of it is how we respond to this emergency. The best system is not one that's built for emergencies, but strengthens those systems that are in use every single day. In public health jurisdictions, there isn't just a pandemic. There's a pandemic and then a foodborne outbreak, or there may be a measles outbreak. If we don't have the systems in place to address those, as we clearly demonstrated, we won't have the ability to respond to these national emergencies. So you build up that system, and that means sustained funding. We have counties here in North Carolina that don't even have epidemiologists, the people who go out and investigate these diseases. We don't have environmental health specialists. So if we identify what that baseline of quality of public health interventions to protect the public's health every single day as the initial level of funding that should be at both the local, state, and federal level. Then from there, we build in the surge capacity. And this is where the public-private partnership comes in. As we responded and built our plan when I was state health director in Illinois, we included the healthcare system in there. And we built a system that could respond by drawing up those resources, by having surge capacity. So it is a level set of funding and then resources to be able to make that surge when the next pandemic occurs.
Some of the funding, as we know, that's flowing right now is coming through the CDC's ELC grant program. Hemi, I'd love to hear your thoughts in general on whether, what sorts of avenues we could take moving forward to make sure that this funding is both enough and sustained.
Sure. In states, there's ELC funding, there's ARPA funding, there's different buckets that states are using for public health. I will say public health modernization, including the data piece. And I'll just maybe give you a couple of examples that I found interesting and hopefully can provide some inspiration for other states. So Oregon is making a $30 million investment in public health modernization, including the underlying data infrastructure. And that's really to build up their statewide public health data system. And they want to be able to collect comprehensive, relevant, and secure health data to identify and mitigate risks to health, and also to really identify where there's disparate impact, especially for communities of color. They really want to be able to hone in and identify where is the problem at the community that we can address. They also wanted to John's point, increase their local epidemiology expertise to improve their community's ability to identify and track risk and have other quality improvement initiatives. And I think to Charity's point, they're actually building out with partners a framework for using the data to identify leading environmental risks to human health and corresponding plans to mitigate risks. So that's one example but I will just say this is a state coming up with it on its own, a legislature that's supportive of it and a governor that is sort of, leading the way in investing. Not to get political on this call, but I don't think you'll see the exact same action across every single state and local public health jurisdiction. That's my point earlier. I do think having some federal guidance, markers, ability to have sustained funding with, measures that states have to meet is a way to ensure that these types of investments can be made across the country with a similar goal in mind, so that we can have interoperability and sort of a consistent standard across the country.
Thanks for that. Charity, I'd love to go to you now. I've had several conversations in just the last week where global health leaders and local domestic public health leaders have been talking about pandemic preparedness and reframing pandemic preparedness as a national security threat. I think there have been lots of conversations around this topic before. But in what ways do you think that reframing might be beneficial in terms of funding for things like data modernization in the US and also surveillance globally, as we prepare for the next pandemic?
Well, I'm heartened to see that conversation evolve, the global conversation, that this is a matter of national security. And the way that I think that relates tactically to fixing our data and intelligence systems is that when we look across all of public health or all of government at the system that we have, and we realize that we have to have an intelligence platform that moves faster than the pathogen if we have a shot at containment. I'm very passionate about containment. If we miss our shot at containing a fast-moving pathogen in the beginning, this is the price we pay. We pay an economic price. We lost 1 million American lives. This is the price of losing at containment. So how do we preserve our option of containment as a country? Well, it's building these data integration systems across all 50 states with real-time intelligence so that every node in the network can see the decisions, the actions, the outcomes, so that as the threat grows and changes, we have the ability to respond as a whole of society with one unified response. The cost of losing at containment is just too high. And so I approach the national security perspective with that in mind, that achieving containment, which we didn't even try with COVID because we didn't have a system that could do it. Achieving containment starts with a modern threat identification intelligence platform. And that's why this conversation is so important. That's why it's a matter of national security.
Thanks for that. We did have one question come in along these lines. Let me just go to that now. So this person asked more globally about future pandemic preparedness and what role organizations, global health organizations like the Global Fund, what role do they play in helping countries around the world, including the US, prepare for future pandemics? Are there discussions we're not having about pandemic preparedness that could include funding from these other global health organizations? You know, we've been very focused on the domestic response and Congress's response, but maybe we should broaden that conversation up. So I'll throw it to anyone who wants it.
I'll just start off by saying that what we've learned with COVID is that the organisms that are responsible for pandemic do not honor state boundaries. They don't honor national boundaries. And that we are all connected. Millions of people every day are crossing international borders. And if there's an outbreak one place, it will come to this country. So the issue of thinking about global pandemic preparedness is an issue for our own national security. And it's one that we have to take into consideration as we think about funding and also about building infrastructure.
If I could just add on to that, I agree with everything John said. And I would add, you know, I'm very passionate about protecting the most vulnerable communities. That means having global intelligence, because a threat anywhere in the world is a threat to every vulnerable community everywhere. You know, when I studied tropical medicine, I got a master's in tropical medicine 20 years ago. It's now become an antiquated term. There's no such thing necessarily as a tropical disease that we won't see in the United States, that the threats we see anywhere will literally end up here within 12 hours. And so the threat of a future pandemic and a worse pathogen has actually increased. And that's why I think it's a great topic of the role that the global players have, you know, governments, nonprofits, academic institutions, private sectors globally, to put together a global intelligence threat identification platform for the benefit of all. And absent that, we're going to be no better off when the next one comes.
Thanks for that. We have one last quick question. Hemi, I'll throw this one to you. This person asks, what can we do about the reoccurring problem of scrambling to address public health emergencies in real time, or after the fact, I mean, instead of following recommended actions in advance? So, you know, I think this person is basically getting at the point that we've seen throughout COVID, state, local, federal agencies really scramble to keep pace with the virus. What lessons can we learn from that action? And should we be following recommended actions in advance of all of this happening? How do we ensure our health system does that?
Is ready. I think that goes back to all of the things that we've been talking about on this conversation of, is this the moment we're going to really reflect back and say, these are the lessons learned, and this is where we're going to make the investments to make things better? And I think across the country, at least at the state level, because that's what I follow, there is a number of commissions popping up and advisory boards where they're really trying to bring in a lot of different types of folks across the community to understand what could we have done better? What should we really be investing in to prepare for the next time around? That's data, but it also goes beyond data. It goes to sort of communications and messaging. It goes to sort of understanding your capacity and your ability to surge, like we talked about earlier in this conversation. It's like making sure you have the partnerships in place to be able to pull in what you need when you need it. I mean, a lot of those were created, right, during COVID-19. We didn't have those set up in advance. And I'll just say, I think back to the point of like, gosh, wouldn't I love just a sort of a global surveillance system where we're going to know across the world, like when there's an outbreak and where we're going to all be able to be prepared. I do feel like that's a long ways away. And I'm a very practical person because I work on state policy. And I think we have a lot to do just to kind of build up, frankly, trust between the state and the federal government. There has been sort of a lot of mixed messaging across both administrations, right? And the states, I think in the beginning of the pandemic, felt like they were forced to lead the way and they did their best. And there were a lot of challenges because we weren't prepared at a national level and we weren't prepared at a state level or a local level across the board. And so, you know, when we're talking about, you know, data systems that like a one data system across this country, it's like, wow, what a great out of the box idea, but how the heck are we going to do that comes to mind. And I think of a lot of work that would need to be done to really build up the trust and like the how of how to accomplish something like that when we have a country that is, it's their states, and then there's the federal government, and we have operated that way for a long time. So I guess I just put that sort of point of realism into the conversation of kind of where we go next.
Thanks for that. That looks like about all the time we have. Anand, I'm going to throw it back to you.
Thanks, Erin, and thanks for moderating the discussion. Thanks to all the panelists for the informative discussion. It's so important to have that local and state perspective, and I think there are a lot of takeaways here for policymakers and health leaders. We hope you and the audience enjoyed today's program. Thanks for your participation and tuning in, and we look forward to future discussions as well as hopefully timely policy action on many of the issues discussed today. Until then, thank you once again, and take care.